Today, we are unraveling a seriously high-stakes medical detective story. We're looking at a condition that is, frankly, terrifying, but also brilliantly logical, and it requires absolute clinical precision to survive. We're talking about heparin-induced thrombocytopenia, or HIT. I mean, just imagine administering a drug designed specifically to prevent blood clots, only to watch it trigger this wild cascade that causes catastrophic clotting throughout the entire body.
It's the ultimate medical paradox, right? Why would a life-saving blood thinner actually cause a massive, potentially fatal blood clot? This is the central question of HIT. It creates this intense ticking clock scenario where the very medication you're using to save the patient is suddenly turning their own immune system against them. Every single minute counts here, and a misdiagnosis, well, it can cost a patient their limbs or even their life.
All right, Section 1, the crime, pathophysiology of a paradox.
Okay, let's dive into this. To actually solve this mystery, we have to go straight to the biological scene of the crime. We need to look at exactly what happens when the immune system just goes completely rogue. We often think of HIT as a drop in platelets, like a bleeding risk. But actually, scratch that, that is completely wrong. The central clinical danger of immune HIT is thrombosis. It is a highly prothrombotic state. So let's walk through this biological chain reaction with some forensic precision. Step 1, heparin, which is negatively charged, electrostatically binds to platelet factor 4, or PF4, which is a positively charged protein released from platelet alpha granules. This forms these ultra-large, highly immunogenic complexes. Step 2, the immune system develops IgG antibodies that specifically target these complexes. And Step 3, these IgG antibodies bind to Fc gamma R2A receptors on the platelets, which cross-links them. This causes massive platelet activation, releasing even more PF4 and creating this vicious, self-amplifying loop of massive thrombin generation. So to put that into perspective, it's an immune thrombotic syndrome, not just a simple platelet drop.
And this biological bomb, it has a very specific timer. The classic timing for HIT to develop is 5 to 10 days after starting heparin, because that's exactly how long it takes to generate those pathogenic antibodies. But you have to beware the rapid onset. If a patient has circulating antibodies from a recent heparin exposure, usually within the last 30 days, their platelets can plummet within literally hours of re-exposure. On the flip side of that, there is delayed onset, or autoimmune HIT, which can strike 15 days or more later. In that scenario, antibodies just continue to activate platelets even in the total absence of heparin.
Moving on to Section 2, the investigation, scoring the suspect.
So, we have the biological mechanism, but now we need to investigate the actual patient. Before drawing a single drop of blood for laboratory testing, guidelines from bodies like ASH and BJH demand we establish pre-test probability. Why? To avoid dangerous false positives. If you just test everyone blindly, you will absolutely end up with those false positives. We need a rigorous scoring system. Enter the 4T score. Notice how beautifully this categorizes clinical suspicion. You score the patient from 0 to 2 across 4 specific domains: thrombocytopenia, timing, thrombosis, and other causes. You tally the points up. A score of 4 to 8 means intermediate to high probability. But if the score is 0 to 3, it means low probability. Now, what's really interesting about this score is its incredibly high negative predictive value. A genuinely low score means you can often confidently rule out HIT altogether and avoid unnecessary, potentially harmful testing.
Within that score, there is one number you literally must burn into your memory: 50%. When we're scoring the thrombocytopenia domain, we are looking for a greater than 50% fall from the patient's baseline platelet count. It is the percentage fall that matters most, not just the absolute number. Let's say a patient drops from 420 to 180. Their platelets are technically still in the normal range, right? But that is a greater than 50% drop. That is a massive red flag for HIT.
But we have to make sure we are chasing the right suspect here. Our main false lead in the ICU is DIC, disseminated intravascular coagulation. Notice the key differences in their coagulation profiles. Both conditions cause a drop in platelets, but in DIC, the coagulation factors get aggressively consumed, so you're often going to see a prolonged PT and dropping fibrinogen. In isolated HIT, PT and fibrinogen usually remain perfectly normal and unconsumed. Furthermore, if you see prominent schistocytes on the blood smear, you should really be leaning heavily toward DIC or a microangiopathy, not HIT.
Section 3, the forensics, labs, and quality control.
Once we've established high clinical suspicion through the 4 T's, we move into the laboratory forensics phase. The precision and stringent quality control here will literally dictate life or death decisions for your patient. We basically have 2 main weapons in the lab. First, immunoassays, like the PF4 ELISA. These have incredibly high sensitivity. They detect the actual presence of the antibodies, but they have lower specificity, heavily relying on the optical density, or OD, of the result. Then, on the other hand, we have functional assays, like the serotonin release assay, or SRA. These have incredibly high specificity because they determine if the patient's antibodies actually activate normal donor platelets. Just remember, a positive ELISA does not automatically mean clinical hit, especially if the optical density is weak.
Running these tests requires absolute rigor. Laboratories have to adhere to strict quality control. They must use positive and negative controls on every single run, verify lots, and strictly define those optical density cutoffs. They must perform pre-analytical checks for hemolyzed, lipemic, or icteric samples. Furthermore, using IgG-specific assays is heavily preferred because it just drastically improves clinical specificity over the polyspecific ones. So the crucial point is this: a casually run or casually interpreted assay will inevitably lead to disastrous misdiagnoses.
And speaking of misdiagnosis, we have to talk about the cardiac surgery trap. Cardiopulmonary bypass absolutely wrecks platelets and frequently generates non-pathogenic anti-PF4 antibodies. If you test wildly here, you're going to get false positives everywhere. You have to follow the post-op timeline carefully. It is totally normal for platelets to fall immediately post-op on day 1 and start recovering by day 3. But if they recover, and then you see a second fall starting around day 5 to 10, that is the dreaded biphasic fall, and that is highly suspicious for true HIT.
If the ELISA is positive in a case like that, you confirm with a functional assay like the SRA, and this beautifully illustrates the biology in action. For QC, the lab uses a low heparin condition, which perfectly aligns the antigens, causing massive platelet activation and serotonin release. But then, they use a high heparin inhibition condition. The massive excess of heparin actually disrupts those ultra-large immune complexes, thereby suppressing platelet activation. That suppression proves the antibodies are specifically targeting the PF4 heparin ratio.
All right, Section 4, Disarming the Bomb, Acute Management.
Okay, so we have our clinical suspicion, we have our labs running, now we have to move to the high-stakes phase, treatment. If you calculate an intermediate or high 4T score, you do not wait for the labs to come back. You must act immediately to disarm the bomb. The very first step is intuitive, but absolute. You stop all heparin immediately. Unfractionated, low molecular weight, even the heparin flushes and coated catheters, all of it. But listen carefully. Simply stopping heparin is never enough. The thrombin generation has already been unleashed. The patient remains a highly prothrombotic, ticking bomb. You must start alternative anticoagulation.
Here is your guideline-approved non-heparin arsenal. First, argatrobin. This is a direct thrombin inhibitor cleared by the liver, making it great for renal failure patients, but it falsely prolongs the INR, which kind of complicates things later on. Then there's bibiliridin. This is another direct thrombin inhibitor, but it has a very short half-life and is cleared by proteolytic and renal pathways, making it ideal if the patient needs urgent surgery or a PCI. Fondaparinux is an indirect factor XA inhibitor, heavily reliant on renal clearance, but it beautifully avoids forming those PF4 complexes altogether. And finally, DOACs, like rivaroxaban or apixaban. These can be used, but only in selected clinically stable patients, definitely not your crashing ICU admissions.
Now, as you transition these patients to long-term care, there is one rule that must echo in your mind. Never start warfarin early in acute HIT. This is a cinematic, fatal trap in acute management. You absolutely do not touch warfarin until the platelets have substantially recovered.
If you violate that rule, you cause venous limb gangrene. Warfarin works by inhibiting vitamin K-dependent factors, but it rapidly depletes protein C first. Protein C is a natural anticoagulant with a very short half-life. If you tank a patient's protein C when they are already intensely prothrombotic from HIT, you cause catastrophic microvascular thrombosis. Their extremities will turn black and necrotize, literally requiring amputation, all while you can still feel perfectly normal palpable arterial pulses. Terrifying, right?
Section 5, High-Yield Clinical Pearls.
Let's move to and see how this all builds into our final, actionable clinical protocol. We've covered the paradoxical biology, the clinical scoring, the strict lab forensics, and the critical treatment pathways.
Let's distill this entire explainer into the hematologist's ultimate pearl. Do not diagnose HIT just because platelets dropped after giving heparin. And do not diagnose HIT just because a sensitive ELISA came back weakly positive. True diagnostic certainty is achieved through concordance, a compatible 4T score, plus a strong optical density on the PF4 immunoassay, plus a positive functional assay proving platelet activation. That is HIT.
It is a seriously harrowing clinical scenario. I mean, we give heparin millions of times a year, barely thinking twice about it. But understanding the electrostatic dance between heparin and PF4 and how our own IgG antibodies can weaponize our platelets to cause catastrophic clots, it really reveals the razor's edge of modern medicine. So, what does this all mean? How does a drug meant to save your life, turning your own immune system against you, change the way we view everyday pharmacology? It reminds us that there are no perfectly safe interventions, only calculated risks requiring extreme clinical vigilance.